I'd like to introduce our BioCrossroads CEO, Patty Martin. Patty's going to get us kicked off today to talk a little bit about vaccines and then make the introduction to Dr. Caine. If you could please use your chat feature, your Q&A feature to send any questions that you have to any of the speakers, and then we'll have a panel discussion for the entire group that will use that feature as well. But feel free to send any questions you have to the Q&A panel on the feature as we discuss. We'll get started now. Thank you.
Chivette, I'm not.
So I'm going to go ahead and get started. Hello, everyone. My name is Patty Martin, and I'm the president and CEO of BioCrossroads, and we are absolutely thrilled to have you with us here today. As was just mentioned by the voice of God, we will want to make sure that you notice the Q&A feature on your Zoom screen, and so that you can have the opportunity to ask questions as we go along. We're very excited about this panel. Obviously, vaccines have been a hot topic, and we wanted to take the opportunity today to ground us all in some of Indiana's history around vaccines. And so this discussion is really meant to just lay the groundwork for what it takes to bring a vaccine across the finish line, and importantly, the role that Indiana has played in bringing important vaccines to market. I'm going to share a little bit about Lilly's history, and we're going to have our friends from IU School of Medicine also speak to their history. Our goal today is to perhaps avoid the topic specific to COVID vaccines, because this is meant to ground us in our history. And then going forward, here in a couple of weeks, we will have additional conversations to bring us up to speed with the current situation with the pandemic of COVID-19. And to that point, we would love to have your feedback on sessions and any additional questions you'd like to have answered as we move through this crazy time. And if there are questions that are of specific interest to you that we think that a Frameworx would help address, please include those in the Q&A in the chat, or send us a message separately after the show. And so what I'd like to do now is take a little memory lane down the polio vaccine and give you some history there, and give you Lilly's history there. And if I could go ahead, I'm going to go back here. I believe we have an agenda slide. Could we go back to that real fast? Great. So, so the agenda for today is, first I'm going to give you some history on the polio vaccine and Lilly's role in that, which is actually very exciting, and history does have a way of repeating itself. And then Dr. Virginia Caine will join us and give us an introduction to all things that are happening from her perspective in the public health of the state of Indiana and Marion County. And then we have Dr. Brown and Dr. Zemet joining us to speak specifically from the IU School of Medicine's perspective on vaccines and the role that Indiana School of Medicine has played. And Darshan Shah, our Chief Technology Officer, will host that panel. So we'll go ahead and get to the next slide. Thanks. So this was a very interesting educational experience for me, going back and reading the history, and we will make some documents available to you on our website that provide some of this history. But interestingly, you can see on this slide that it basically, the polio vaccine was a 10-year journey. And you think about the context of the time frame that we're trying to address COVID-19 right now, it's certainly on an accelerated time frame. And interestingly enough, polio had been around for many, many years, thousands of years. And what was important was when the discovery was made that the vaccine attacked the nervous system, and then ultimately that would circulate in the blood. So in 1950, the way this slide is outlined, you have Lilly's participation above the line and the general activities happening below the line. And so in 1950, Lilly actually created a tissue culture lab. And so I think it's important in life sciences to understand the investment that has to be made and how early investment has to be made. This is not something that can happen on a dime. So back in 1950, Lilly created a tissue culture lab, and was actually then able to grow the polio virus in their lab in 1952. And simultaneously, of course, Dr. Salk was working on the vaccine and concluded the initial trials in 1953. And so that was obviously a very important date when the world was able to recognize that there could potentially be a vaccine for this debilitating disease that predominantly affected many children. Lilly proceeded with its tests and was able to grow the virus in monkey kidney tissue. There's more history on that actually in a YouTube that's available that we can make available so that you understand the history. And then produced its experimental polio vaccine lot in 1953. So things were moving along, but understand that's still a 3 or 4 year time frame on top of hundreds of years of this debilitating virus. Later in 1953, Lilly and 4 other companies working with the National Institute of Health agreed that they would try to make the clinical trial material to be used in a large-scale vaccine clinical trial. And so at that time, there were 4 manufacturers, and the field trial actually got started in 1954. At that time, Lilly decided to build at risk. And so this is a term we're hearing a lot now from all kinds of players that are talking about the COVID-19 pandemic and vaccines and therapeutics. The decision to build at risk is a critical one because you're investing capital on the hope that your vaccine is going to be successful. And we see that a number of players, including Moderna and J&J, are already doing this currently. In fact, Catalent down in Bloomington is manufacturing in advance vaccine for a number of the current players. So the decision to build at risk is really important because that's when you're putting your capital, you're betting, you're making a bet, right? So then in 1955, Lilly shipped 3 million doses on April 12th to 13 states that were located in the south and southeastern part of the United States, where the virus was the most aggressive. So that was the first shipment. And interestingly enough, later that year, Lilly shipped its 10 millionth dose. So we know how many hundreds of millions of doses are being made currently. And it was amazing just how quickly Lilly was able to ship 10 million doses in 1955. Now, if you look at the lower part of the slide, you'll see that there was a safety halt. So in mid part of 1955, there was a recall of another manufacturer. And so the federal government and the NIH had to reassess the safety precautions and manufacturing quality standards of the vaccine. And so there was actually a halt put on shipping of any additional vaccines. And new standards were generated then later that year. I think that was in July. So what's interesting there is, again, as a precursor to what we could anticipate happening with this vaccine, it's not going to be unusual that you're going to have hiccups along the way and that you need to retrench and make sure that everything is perfectly safe. And that process, of course, takes additional time. So at that point in time, once the new standards were issued, Lilly actually upped its capacity by 50%. And what was interesting about the capacity is it wasn't as difficult to grow the virus and make the vaccine as it was to do the quality controls. I think the number that I recall reading was something like 116 days of quality, the process, the critical path for getting a lot released. So they added additional capacity in order to deliver more to the market. And so then an important thing happened, again, relevant to what's happening now. Later in 1956, this was not Lilly specific, but the New England Journal of Medicine issued a seminal article, or published an article, that demonstrated that 1 dose of the vaccine was 53 to 65% effective, and 2 doses were 67 to 80%. So again, keep that in the back of your head as we move forward on our next session to talk about the COVID vaccine, because again, no vaccine is entirely 100% effective. And the ability of a vaccine to reduce the impact is also not exactly known. So it was important to know that this was a 2-dose vaccine at the time, and that they were continuing to gather information to understand exactly what the requirements should be. So at that point in time, a great number of people actually had been vaccinated. Lilly shipped in 1957 its 100th millionth dose. And given the number of folks who had been vaccinated, there began to be some apathy in the system, thinking that, well, we have this licked. And so actually Lilly ended up destroying 27,000 doses in 1957 as that apathy continued into 1958. And then unfortunately a second spike happened. Well, I shouldn't say second, but another spike happened. And there was significant demand that re-upped. So again, this cycle of the process to develop the vaccine, ensure that it's safe, make sure that there's manufacturing and distribution. Ultimately, by 1959, in July of 1959, there was a shortage. And so that manufacturing capacity had to bump up again. And over the 10-year time frame, by 1959, Eli Lilly and Company actually distributed over 200 million doses, which was over half of what was distributed by the industry from United States manufacturers up and through that point in time. So we just wanted to lay this groundwork because this takes us back. I was born in 1960, so this was happening I actually remember getting the polio vaccine. It's interesting to consider this decade of evolution of the polio virus and Indiana's role specifically through Eli Lilly and Company in bringing it to market and ensuring the safe product was distributed and then actually consumed by over 200 million doses. So with that as background, and certainly a number of those points with respect to the history we think could repeat themselves as we go forward, I'd like to now turn this over to our next guest, which is Dr. Virginia Caine. And Dr. Virginia Caine is a wonderful friend and colleague, and she is the Director and Chief Medical Officer for the Marion County Department of Health, as well as being an Associate Bicentennial Professor of Medicine of the Medicine Division for Infectious Diseases at the IU School of Medicine. And it is my distinct pleasure to turn my camera off and have you listen to the wise words of Dr. Caine. Virginia, it's all yours.
Well, thank you, Patty. This is a great subject, especially as we're in the COVID-19 pandemic, and then we're facing the winter with influenza coming on board. If I could have the next slide. My disclosures are I'm on a Speakers Bureau promotional education program from Gilead and GlaxoSmithKline. Next slide. So let me tell you why vaccines are so important to us. They represent some of the most impactful public health advances seen to date. Currently, right now, we have 16 diseases that are now preventable. And probably, as Patty just talked about, one of the most deadly infectious diseases and most contagious diseases we had ever faced was smallpox, which was finally eradicated in 1949, and our polio in 1994. Measles, we were able to eradicate in 2000, but we still have a lot of measles across the border in Mexico, and rubella in 2004. But I think you may have remembered about Disney World. I think in 2014, we had a number of international visitors to Disney World in California, and we had nearly 200 cases that spread over 7 states. So we're still always at risk, and it tells you how critical vaccines are in our country because of international travel. When we looked at immunizations, the routine immunizations of children that were born between 1994 to 2018 has prevented more than 419 million illnesses. Next slide. And we know that there's an estimated 45,000 adults who die annually from complications due to vaccine-preventable diseases. And if we just looked at influenza, we have an average of 200,000 United States hospitalizations due to the seasonal flu complications occurring each year. Here in Marion County, just in April and May, all of our hospital systems, critical care units were at full capacity. Our emergency rooms were jammed. We were seeing like 2,500 ER visits for COVID-19 on a daily basis here in Marion County. And so you will understand as we get closer and closer to winter and our flu season, we're going to almost have like we call a double whammy in its impact. So United States now is home to 4% of the world population, and yet we account for more than 20% of both our COVID-19 cases and our death. Next slide. One of the things that has gotten a lot of attention lately was, wow, should we consider herd immunity? Just let these people in our community contract the disease naturally, and then that may be an effective tool in order to curtail or eradicate this COVID-19. So I wanted to just talk about what is herd immunity and how does it work. So what happens is if you're not immunized, okay, you have no immunization. So if only looking at my first little diagram that's with the blue patients, only if you get a few people vaccinated, it doesn't protect you from transmitting that infection to other people. And so the virus, as you go to the little red patients and you only see that one little blue patient who's vaccinated, the virus continues to easily spread. So depending on if you have a considerable number of people who are vaccinated, then that provides protection, especially for those individuals who cannot get infected. So like for the flu, you can't give a vaccination to a baby up to 6 months of age. Or you may have some individuals based on their immunocompromised manner may not always be able to get a vaccine. So as a result, it will help to prevent transmission of the flu to other people, the higher the number of folks that are immunized. Now we can, if we get 40 to 50% of our patients who are receiving the influenza vaccine, it provides some protection for herd immunity, but it is dependent upon how contagious that disease is. And we know that COVID-19 is almost 3 times being contagious compared to, say, influenza. So it would require almost a much greater 95% of individuals needing to be immune to COVID-19 in order to provide herd immunity protection. The same thing with measles. Measles is so contagious that you would need a community of somewhere about 90 to 95% of them to be vaccinated to provide herd immunity. Next slide. So we will know that influenza viruses and the COVID-19 will likely both be spreading in the fall and winter. So it is so important that if we want to protect not only our healthcare workers, we want to limit our hospitalizations related to influenza so that we do not have 2 epidemics going on at the same time. So, we got one of our major challenges was we didn't have enough personal protective equipment. The N95 respirator masks disappeared on us because I think being bought by some other countries that had a lot more money for some of our companies that we were providing this personal protective equipment or materials. But just think, of the amount of personal protective equipment we would require, and just think how quickly our hospitalizations will be full, our emergency rooms will be full. So the effectiveness will be really critical related to this while trying to maintain the social distancing. And I just want to highlight this one little point. This chart highlights the effectiveness of our influenza vaccines in the past. And so you can see way early, we had some higher vaccination effectiveness, 50, 60%. But in the more recent years, last year was at a 45% effectiveness. The year before, though, down at 29% effectiveness. And we really want to see our influenza vaccines effectiveness somewhere between 40 and 60%. So we are in the United States experiencing over 7 million cases of COVID-19. We are over nearly 170,000 cases in the state of Indiana for COVID-19. And so we have our job cut out for us. And so the value of vaccines are saving lives and is so critical. We are fortunate to have so many vaccines now in the pipelines for infectious diseases. Thank you, Patty.
And thank you, Dr. Caine, for that really wonderful background and foundation regarding infectious disease, as well as that call to action, really, regarding the flu vaccine. For everyone, my name is Darshan Shah. I'm the Chief Data Officer here at BioCrossroads. I'll have the opportunity of moderating the panel here momentarily, but now we're going to pivot over to our friends over at the School of Medicine. As Patty was mentioning at the beginning, today we're taking a look back at the historical leadership that Indiana has had, when it comes to vaccines. Our next guest from the School of Medicine played an integral role in that development and deployment of the HPV vaccine, and specifically Gardasil. We're starting this discussion here today on what it takes to get a vaccine like Gardasil across the finish line. And the goal of that was to lay that groundwork, that historical perspective, so we can draw on comparisons and similarities on what it'll take to get a COVID-19 vaccine, not only developed, on the bench and in the clinical trials, but also widely accepted. So let's take a look back at the clinical trials and the School of Medicine's role with the HPV vaccine. And with that, join me in welcoming Dr. Darren Brown, Professor of Medicine in the HPV, Dr. Darren Brown, Professor of Medicine, Microbiology, and Immunology at the School of Medicine, and within the Division of Infectious Disease. With that, Dr. Brown, the floor is yours. Thank you so much.
Thanks for that introduction, Darshan. Let me just make sure I got everything right here. Is this looking good now?
It's looking great.
Okay. Thanks. So vaccines are the safest and most effective things that we do as physicians. And when I started my infectious diseases fellowship in 1985, I really didn't know much about vaccines, and I didn't know much about HPV, certainly, because nobody knew very much about it. We now have a very safe and effective vaccine that protects us against HPV infection. And I just want to go through a few slides to show you some of the things that had to happen before this vaccine could be developed. Step one is really understanding the virus. And we know that cervical cancer is a very common malignancy globally. It's the second most common in women, most common in poor countries. Oncogenic types of HPV were shown to be the cause of cervical cancer, and this was Dr. Zurhausen's lab in Heidelberg, for which he won the Nobel Prize in Medicine for. We know that HPV also causes genital warts and a bunch of other cancers of the anogenital tract and oropharynx. This is a double-stranded DNA virus with a protein shell, and it's called the L1 major capsid protein. I can't seem to advance. There we go. I just wanted to show you this slide. This is from WHO, and it shows you the real hot zones in red, where cervical cancer is the highest incidence, more than 10 times the incidence that in Australia, some other countries such as the US and Canada, and also in Latin American countries. The HPV virus can be expressed in bacteria and yeast cells, but only the L1 protein itself, if it's expressed, can self-assemble into these things called virus-like particles. And I've shown you some of these here. They contain no genetic material of HPV, so they can't transmit infectious disease. However, immunologically, they're exactly like the real virus. They elicit a very strong immune response. And in 1994 and 1995, some people at Rochester, friends of mine where I did my fellowship, and at IU School of Medicine, we showed that these VLPs are both immunogenic and then, importantly, can elicit neutralizing antibodies. In other words, if an animal is immunized with virus-like particles, we can take that sera and actually neutralize live infectious HPV. And that was a big deal. That we did that first here at IU School of Medicine. That was in 1996. And we used some viruses produced by John Kreider, who was a veterinary doctor at Penn State, and developed a way to isolate HPV-11 in an athymic mouse model. And if we added those live viruses to a piece of human tissue and put it into an athymic mouse, then took out the tissue 3 months later, if there was a neutralizing serum added to that little mix of virus plus tissue, then no tumor would grow. But if no neutralizing antibody was in that serum, a benign tumor containing HPV-11 would grow. And this sounds like a rather bizarre system, but HPV doesn't grow like other viruses do. It doesn't grow in cell culture systems like influenza or other viruses do. So this was really a nice way to show that HPV VLPs could elicit a neutralizing antibody response. And that was really critical. Nobody wants to make a vaccine unless we have a pretty good idea that it might actually work. But based on that information, we did the very first human trial of any HPV vaccine in the world. That was done here at IU. 110 women down at IU Bloomington were immunized with either placebo or one dose, one of 4 doses rather, of HPV-11 VLPs. 3 times, 3 doses were given, day 0, then months 2 and 6. Then we tested all sera after about 3 months after the last dose for neutralizing antibody in that system I told you about. And that was a very long and tedious endeavor. We also collected safety data. This is what we found. We found that women who got placebo did not make neutralizing antibody. This is antibody titer over here in the y-axis. These are the various doses that we gave. So you can see neutralization, which is shown in the little plus signs, occurred at a dose-dependent manner. So the highest dose we gave, 100 micrograms of virus, we had the most effective neutralization. This was a very safe vaccine as well. This was the monovalent HPV-11 vaccine, and most of the women did have minimal local reactions that were dose-dependent. There were very few systemic reactions, mostly low-grade fevers and headache. Phase 2 trials were then done, both at IU and in conjunction with other investigators in Europe and in Brazil. We tested a monovalent HPV-16, then a monovalent HPV-18, and finally the quadrivalent vaccine, where we combined HPV-6 and 11, which cause genital warts, with HPV-16 and 18, which are common causes of cervical cancer. The phase 3 study was done all over the world. There were 13 countries involved. This trial was designed by Laura Kautsky at University of Washington, Susan Kajer in Copenhagen. I participated in the design as well as some other people. And of course, the folks at Merck sponsored this. And this was the pivotal study that demonstrated a very high degree of efficacy of the vaccine in preventing CIN1, which is basically a cytopathic effect of acute infection, but importantly, CIN2 and 3, which are precursors to cancer. CIN3 is carcinoma in situ of the cervix, and then adenocarcinoma in situ. And as you can see, vaccine efficacy was extremely high. This is amongst the approximately 16,000 women in the per protocol efficacy group. Additional studies at IU School of Medicine were then done. I helped plan some of these, but these were group efforts, all sponsored by Merck. Vaccine efficacy in males, vaccine efficacy in mid-adult women up to age 44. And finally, the 9-valent vaccine. A young woman who got her PhD in my lab went to Merck in 2001 and helped design the 9-valent vaccine, which was tested and shown to be highly effective in prevention of infection, persistent infection, and disease by 9 types, including 6 and 11, which are the genital wart types, and then 7 oncogenic types, including HPV 6 and 11. This all led to FDA approvals, the first one in 2006 or 14 years ago, and some FDA approvals up to 2011. Step 5, you're going to hear more about this from Dr. Zimmet, but utilization of any vaccine is critical. I mean, it's great that we made a safe and effective vaccine, but as you can see in this slide, we have a range of utilization. Countries such as Australia have a very high vaccine uptake and have already demonstrated marked reductions in cervical precancers and cancers. Here in the United States, the uptake is a bit less high. The lowest vaccination rates, unfortunately, are in populations within our country that have the highest rates of cervical cancer. And where I do most of my research now, which is through AMPATH in Kenya, we have very low uptake in Kenya. Kenya is one of the very highest incidents of cervical cancer. And 14 years after the vaccine has been approved, we still have fewer than 1% of young girls who have been vaccinated. This is my last slide. And I just wanted to tell you briefly some of the ongoing research that we have at IU School of Medicine related to HPV. Some is vaccine related, some isn't, but we have active groups still working on mechanisms of HPV oncogenesis. We have pretty good ideas how HPV causes cancer, but there's still a lot of unanswered questions. Dr. Andrefy's lab, who's the chief of dermatology and a former classmate of mine at Rochester, is working on development of anti-HPV compounds. Dr. Zimmet and several other very fine investigators are working on utilization and barriers to HPV vaccination. My studies involve natural history of HPV in young men and women in the United States and in Kenya. We recently were refunded by the NCI to study epidemiology of HPV in Kenyan women who are living with HIV/AIDS. And I also just recently, in the last month, we were funded to develop a community-based cervical cancer eradication program in Kenya that combines modern era cervical cancer screening of adult women and vaccination of their children against HPV, all in a community-based setting. And lastly, I'm very interested in the immunological response to HPV vaccine in Kenyan children, particularly who have been exposed to aflatoxin, which is a potent immunosuppressive and oncogenic agent. So it's one thing to vaccinate kids, but it's another thing to show that the vaccine actually does what you want it to do. So those are some of the things that we're still doing at IU School of Medicine. A lot of people say, well, you've got a vaccine, so why are you still working on this? Well, this gives you an idea why we're still working on it. We still have a lot we don't know. And with that, I'll stop, and thank you very much for your attention.
Great. And now I'd like to introduce Dr. Zimet, who will be continuing the discussion about HPV more from the standpoint of how it's gained further acceptance kind of in the community. And Dr. Zimet is a clinical psychologist and professor in the Department of Pediatrics at the IU School of Medicine. And with that, Dr. Zimet, the floor is yours.
Thank you. Can everyone hear me okay?
Sound great.
Good, okay. So as Dr. Brown so nicely noted, we have this amazing tool in HPV vaccine for preventing several different kinds of cancers as well as genital warts. As he also implied, there's some problems, and the problem really isn't in the tool itself, it's how we utilize this tool. So how do we finish this job, and how do we make sure that we're preventing as many HPV cancers and diseases as possible? So here are my disclosures. And so what do we need to finish the job? So we, in the United States, unfortunately have a lot of barriers, so we need to find a way to overcome these barriers, which has proven to be quite a challenge. So barriers are present at many levels. I wish it was a simple matter of simply passing some kind of national policy, but that's not really possible in the United States. Part of the reason that Australia has done so well, as Dr. Brown mentioned, is because they have national health policy, national health insurance, so they're able to make changes at the national level that immediately change things at the state and local level. So some of the challenges that we face, again, they're multi-level. I'm going to start at the individual level. The big challenge that we face with HPV vaccine and with other vaccines is fears that the vaccine is dangerous, concerns about shots being painful. Parents will say, my child's too young at 11 or 12 to get HPV vaccine, or my child doesn't need it because I've raised them right. The association of HPV vaccine with sex and with sexually transmitted diseases has been problematic for some parents. Parents also have limited knowledge and awareness even after all of these years. The vaccine was licensed in 2006, so we're coming up next year on 15 years. There's still a tremendous amount that parents don't know and need to know and understand. Other areas of difficulty are really family and social group norms and beliefs. So if a parent is concerned that their family wouldn't approve of vaccinating their son or daughter with HPV, that can be a problem. People wonder whether it fits in with their religion. I have to say there is not a single religion that has doctrine that indicates that vaccines should not be given, but people often think that that might be the case. People are concerned with what their friends think and what they perceive as sort of normative behavior. One of the big issues for the United States is our healthcare system, which is extraordinarily complex, varies from place to place, and can be really difficult to negotiate. But there are actually multiple aspects of the healthcare system that have implications for HPV vaccine delivery. On the left at the top, you see what I call healthcare provider communication. What we found through our research here at IU, as well as other places, is that when healthcare providers give a strong, presumptive, clear recommendation, they achieve higher rates of HPV vaccination. So that healthcare provider communication is key. It's also key to make sure that within practices that everyone is giving the same message. So you may have a healthcare provider who's recommending strongly HPV vaccination, but if there's a receptionist, when a parent comes in and says, oh, you don't want to get that vaccine, that's going to undermine the good work that the healthcare provider is trying to do. So we know this now, that it's really important for every member of the office to be on the same page and to be supporting HPV vaccination. For vaccines that require more than one dose, so HPV vaccine requires 2 doses if the first dose is given before age 15, 3 doses if the first dose is given at age 15 or older. In that case, getting people back for that second and third dose is really important. Does this particular healthcare system have a good integrated reminder recall system so that parents know when to bring their teenager back in for that second or third dose? Standing orders, which are used in a lot of settings, can be a great way to make vaccination more efficient, but they're not always in place. It's a way to kind of decrease the time and the bureaucracy associated with vaccination. And it can be really helpful if healthcare systems or insurers have very clear benchmarks, so expectations for certain levels of HPV vaccine coverage that are expected, and that communication to providers is made. Access to healthcare can be a particular issue. Again, for coming back for that second or third dose, if it's difficult to access healthcare, that can be a real problem. So another barrier in the United States is that each state has its own policies and approaches to vaccination. We have the ACIP of the CDC that makes policy that says, these are the vaccines that are routinely recommended, but each state implements that policy in different ways. So this map, sort of graphically, I try to show how diffuse the different states are in their approaches. But what you can see is this tremendous variability in HPV vaccination coverage depending on state. So there are three jurisdictions, Rhode Island, the District of Columbia, and North Dakota, that are really, really close to the Healthy People 2020 goal, which was 80% HPV vaccine series completion. So those states have done, and jurisdiction, in the case of District of Columbia, have done a remarkable job in getting very close to our goal that we hope to reach this year. On the other hand, you can see some states have fallen way behind. So Mississippi in particular has the lowest completion rate of all the states at 30%. Indiana is quite low as well. It's one of the lowest in the country at 41%. So, and all the other states are somewhere in between. So there's tremendous variability and differences in approaches to HPV vaccination. So part of the difficulty is we don't really have a national policy. We do have the CDC and the ACIP, the Advisory Committee on Immunization Practices, that issue sort of policy statements about vaccination, but it's really hard because we have in some ways a very disjointed approach to vaccination, to communicate and to ensure that vaccines get implemented in effective ways in each state. And politics can unfortunately sometimes play a role in how people perceive vaccines as well. So there's not just state-to-state variability. We did a study using Indiana vaccination registry data from the CHIRP system to look at county-level variability in missed opportunities for HPV vaccination. So across the 92 counties in Indiana, missed opportunity for HPV vaccination was defined as a visit when an HPV vaccine eligible child received another vaccine, either Tdap, meningococcal vaccine, or hepatitis A vaccine, but did not receive HPV vaccine. So a higher number here is worse. So it means more missed opportunities. And you can see in green are the counties that have done the best with under 53% missed opportunities. That's still not great. In yellow are the ones in the middle with 54 to 65% missed opportunities. And in red are the counties where nearly 2/3 or more of visits when a child could have gotten HPV vaccine, they didn't. So there's, not just from state to state, but within state, we see huge variability. Some of it is related to an urban-rural disparity, where rural areas, we know nationwide as well as in Indiana, HPV vaccine coverage is not as good. And finally, I don't know about finally, but we also have, as everyone I'm sure is aware, the really problematic influences of social media. Social media disseminates misinformation and fear about vaccines. There have been cyber attacks on HPV vaccine advocates. There was a pediatric practice in Pittsburgh that was the victim of a coordinated international social media attack because they were advocating for HPV vaccination. Social media can create a kind of sense of false norms. Depending on where people go on social media, who their friends are, and so on, they might have the impression that a huge number of people think HPV vaccine is bad or that vaccines are bad, when in fact that's not the case. The majority of people are pro-vaccine, but it can create a very false sense of what is normative. The social media also has this, we've heard about this a lot in politics, but it can create and particularly magnify existing conflicts. And here are a couple of papers that were published in the last few years. The top one is about that pediatric practice that was attacked and how they responded to it. They responded to it very effectively. And Todd Wolin, who's one of the authors and is a pediatrician in that practice, has really developed a toolbox to counter anti-vaccine attacks. The other article is a really interesting article that came out a couple of years ago that looks at how Russian bots used the debate about vaccines online to magnify and make the debate more and more intense. So, all the factors I'm talking about are interconnected. I talked about individual, social, healthcare system, and state and national, but they're all intricately interconnected. And if we want more parents to vaccinate their children, we really have to, I think, address all of these levels: the healthcare, personal and parental factors, ensuring that we're communicating effectively and educating parents and adolescents. The social environmental factors, including social media, we have to become better at countering the negative influences of social media. Institutional and political factors and policy. We know that school entry requirements make a huge difference in HPV vaccine coverage. Rhode Island has a very effective school entry requirement. And again, as I showed, they are the top vaccinating state in the country in terms of HPV vaccine. Hawaii is going to implement a school entry requirement next year. We also have to address logistical challenges to make sure that people in rural areas have access to HPV vaccine and that there aren't those kinds of barriers to getting vaccinated, particularly for the subsequent doses. So here at IU, as Dr. Brown said, we've been doing this research for a long time. I published my first paper with my colleagues on attitudes about HPV vaccine in the year 2000, and it was the first article on behavioral aspects of HPV vaccine immunization published anywhere. And I've been building on that ever since with a great group of collaborators, including Dr. Brown. This is just an example of a few of our articles. This one was one of the first articles to look at real-world effectiveness of HPV vaccination. We did a really interesting article where we listened to parent-pediatrician conversations about HPV vaccination and analyzed the dialogues. Here's my colleagues at University of South Florida and University of North Texas. We looked at the effect of Rhode Island school entry requirement on vaccination rates. And then we've also been doing intervention research to try to improve HPV vaccination. And these two studies with colleagues at Regan Street and across the university looked at clinician reminders using elaborated clinician prompts and a targeted video intervention for parents in waiting rooms, both of which improved vaccination rates significantly. I also wanted to mention and build on what Dr. Brown was talking about. We have a really unique set up in Indiana, we have and have had for about 8 years a campus, IUPUI Campus Center for HPV Research. The co-directors are myself and Rachel Katzenellenbogen. Rachel does a lot of basic science research similar to what Dr. Androfi does. So Dr. Katzenellenbogen does similar kinds of work. We have over 40 members of our center, including faculty, postdocs, and pre-docs, representing 4 Indiana universities across multiple schools and departments. And the group engages in a wide range of research, everything from the kind of basic science work that Dr. Brown was talking about with Dr. Androfi and Dr. Katzenellenbogen, a lot of clinical science and epidemiology, looking at the natural history of infection, which is a main focus for Dr. Brown and some of his colleagues, Dr. Shu and Dr. Ermel. We have a large group who are focusing on behavioral and social science, and also we have a focus on public health policy. I think, and my final slide. So we have the tools. We have HPV vaccination. For cervical cancer, we also have very effective screening. But in order to most effectively prevent HPV cancers, we need to keep working on these policy and behavior, social media, healthcare access issues if we want to finish the job. Thank you.
Dr. Zemet, that was great. I love that slide there at the end with the cat climbing the fence. But really do appreciate you helping us all understand kind of better as to what it's going to take to, get broader kind of vaccine acceptance. It's not just a matter of getting the vaccine; it's a matter of getting people to take in, getting over that fence. So that's great. I would now like to ask Dr. Caine, Dr. Brown, Dr. Zemet, and Patty Martin to all turn their cameras back on as we pivot to the panel portion of this Frameworx. And for all of you watching, please continue to submit your questions to the Q&A feature here on Zoom. I think we have a couple questions already, and I'm probably going to take a little bit of moderator's prerogative to ask a couple questions as well. And I'll pose them to our panelists one by one. And so just to get us going, I'd like to take the opportunity to ask the first question. And I'm going to direct this to Dr. Caine and then Dr. Zemet first, but I would welcome hearing Dr. Brown and Patty's comments as well. So what is one piece of advice you would offer vaccine advocates, like all of us here on the call, for communicating that message to family and friends who may be a bit more vaccine hesitant? Because I think I remember when talking to Dr. Zemet before, he mentioned there was a lot of people in that middle, that are kind of vaccine hesitant. What kind of advice do we offer to kind of get them over that hump? Dr. Caine.
Yes, so I think it's the communication, and it's almost like their recognition of your expertise. So I think if I say, hey, I've got a vaccine now that I think that your child should get and be interested in, I'd like you to think about getting this vaccine. So that's how we traditionally have said it. But I think it's more appropriate to say, this is, in talking to the parents, it is now time for your child to get the HPV vaccine, and I'd like to either do it today or schedule it really quickly, as though this is a normal process. This is the expectation. If you want to learn a little bit more about the vaccine, I'm happy to tell you, but this is the time for you to get your vaccine schedule for our children. So I think when you do it in that manner, it's an expectation. This is a standard recommendation that we're giving for our children to protect them. Then it's a lot easier for them to be compliant related to this. We have more success that way than, oh, I think this is something new, even though it's been out, like Greg says, since 2004. Yeah, so we get way more success related to doing it in that fashion.
Yeah, absolutely, I agree 100%. And just building on that, so for a healthcare provider, absolutely that kind of presumptive approach where it's presume that it's going to be accepted. And with HPV vaccine, the targeted age is 11 and 12. So there are other vaccines that are in that platform. The other vaccines that are typically given are Tdap, the tetanus, diphtheria, pertussis booster, and meningococcal ACWY vaccine. Now in Indiana, also hepatitis A, which is required for middle school entry as well. So the approach is you bundle them and put HPV in the middle. So if you're a healthcare provider, you say, oh, we're going to administer 4 vaccines today: Tdap to prevent pertussis, HPV to prevent cancers, meningococcal vaccine to prevent a serious brain infection, and hepatitis A to prevent, liver disease, whatever. And so let's get them now. I recommend all of them. Let's get them done now. So it should be like same day, same way, bundled, HPV in the middle. Because if you have HPV in the middle, there's less of an inclination to treat it like something else. So what we heard, so for instance, in the recordings of physicians that we had, the way HPV was dealt with was always as if it was something different, and instead of treating it like every other vaccine. So, and the pediatricians who treated it differently had a poor uptake of the vaccine. So that if you're talking to friends and family, then maybe you take a slightly different approach, where, particularly if you have a chance to elicit from them, find out what they're worried about. If they have worries, educate yourself so you can educate them. Find out where they're getting their information from. And clinicians can do this as well if they get a lot of pushback. Then, you switch from that presumptive recommendation to engaging with the person, to finding out, with a true sense of curiosity, not an intent to humiliate them, but to find out what their concerns are, where they're getting that information from, sort of asking whether, you could provide them with a different source of information, but really to try to engage them in that process. I think it's important that we all post to social media. I just posted on my Facebook a post from the Immunization Action Coalition about flu vaccine and Halloween, because I think if we're not out there on social media, then what you see on social media is all of the lies and distortions about vaccines. So I encourage professionals, any professional who is pro-vaccine, really to be active on social media about it, repost, retweet, that kind of thing.
So I've seen some general purpose advertisements promoting, so like in the morning watching the Today Show. Have you seen any evidence that those sort of general awareness campaigns are useful?
Is that for HPV vaccine?
Yeah.
Or vaccines in general? Yeah, so the commercials I've seen recently have been on Hulu, I guess.
Okay.
And they are Merck. I mean, they're often unbranded, but they're Merck. Merck
Okay.
produces them.
Yeah.
I don't know. I have to assume that the Merck marketing people have evaluated.
Yeah.
I kind of wish sometimes that their marketing research was publicly available, because it would be useful for all of it. Does it help to address HPV vaccine this way? They had this.
Yeah.
They had this whole campaign that was based on the concept of anticipated regret, which is this idea that if you don't vaccinate, how you feel if your child gets cancer. And and so people had mixed feelings about it. It would show a young woman, and that would regress her over time. The did you know? I don't know if you've seen that.
Mm-mm.
Yeah, but
the one I've seen is Not My Child. It's called Not My Child. And and I'll have to watch it again to see. So I just really think, and this is partly why we wanted to do this series of Frameworx, is to, really try to depoliticize and try to have just the facts based out there, so we and our audiences who we know are more informed but still not completely informed on this topic are, have the tools that we need to spread the word.
There's still parents who don't realize why it's recommended for males. They think the only thing they can think of is that it must be to protect his future spouse or something. So
Interesting.
I am astounded because it's been routinely recommended for males since 2011 and it's been recommended since 2009. So I always overestimate how much parents know about this.
Right.
And now, there's now an indication for the vaccine for the prevention of oropharyngeal cancers.
Mm-hmm.
That's a powerful new piece of leverage. I think
Wow.
We've all believed for years that the vaccine would reduce incidence of oropharyngeal cancers, but it's now a label indication. That's fairly recent.
Wow.
And HPV oropharyngeal cancers happen in men much more than in women, and there's been a huge increase.
Wow. Okay. Thank you.
Well, so what I've heard on that first question from an advice standpoint is social media to be able to kind of debunk a lot of the other social media. Just do it. Nike's phrase. It's a matter of, let's not talk about COVID vaccine. Let's talk about all the other vaccines that are available today and just go do that because it'll build the impetus and motivation to get the next one. And then I love the phrase around educate yourself so you can educate others. And I think, that's really, again, like the core of this Frameworx is, the audience that we have here are scientific leaders, oftentimes in our community, leaders in the life sciences community. And these are the kinds of folks that we want to be able to educate to continue to be able to kind of, push that message out to the broader community. So, well said, and thank you for that. Let me go to some of the additional questions unless anyone has more feedback on that one. All right. Well, the next question here, there's a question here from Brian here that says, is there any ongoing research at the IU Med School or elsewhere in Indiana for other cancer vaccines? And that kind of went along with the question that was kind of running through my mind for Dr. Brown and Dr. Zemet in particular, but I'd love to get everyone's thoughts is kind of based on your experiences with the School of Medicine, are there other areas, where you see Indiana having a role or, place where Indiana is kind of showing that leadership even beyond, HPV and polio that we've spoken about today? Dr. Brown,
Darren, I think, is probably best positioned.
I'm not aware of any right now. I mean, there's two types of cancer vaccines. There's the type that prevents infection with an infectious agent that causes cancer, for example, HPV, or EBV. EBV causes lymphoma, or herpes virus 8, which causes Kaposi sarcoma. People have looked at vaccines for those. To my knowledge, we don't have anyone working on the herpes viruses or EBV vaccines at IU School of Medicine. The other type of cancer vaccine is more or less a therapeutic vaccine. For example, in malignant melanoma, there are vaccines that can stimulate a certain part of the immune system to help the body make cells that can attack the tumor. There have been some clinical trials related to malignant melanoma done at the Simon Cancer Center. To my knowledge, we don't have a working group that really is focusing on those types of vaccines at present.
Got it.
Darshan, may I ask a question of Dr. Caine?
Certainly.
So thank you so much for joining us. We know that you're incredibly busy, and thank you for all you're doing to protect us. So I am just going to offer up, you have one or two things that anyone on this call can help you with. What's your ask?
Oh, that's a great one. So, we're seeing our cases increasing rapidly in the state of Indiana for COVID-19, and we're facing the winter. Oh, sorry, my cat's trying to get in my act here. But if I could say one thing, number one, I'd love for everyone to make sure that they get a flu shot and that they encourage their family and their friends and their colleagues to get a flu shot. That would help us tremendously in this epidemic. And then if I could get two more asks, and that is, we're now finding with our rapid increase of COVID cases that a lot now is in small circles. So it's these little small family gatherings inside their homes. There may be 8 or 10 people there that are outside their household that we're now seeing multiple infections taking place with COVID-19. And I know it's so difficult with the fatigue of wearing masks and doing the 6-foot distancing, but watch out for Halloween and fall break for you out there. And then you just got to do that 6-foot distancing, wear that mask, and wash your hands appropriately. Thank you.
You're on mute.
Sorry, I wear mine around my neck now so that I have no excuse to not have it.
Always readily available. Hey, Dr. Caine, I think there is a simple question here, kind of as you're talking about vaccinations, just around, do you know the percentage of fully vaccinated people in Marion County?
So I know the percentage for I think it's for the children. So right now, before COVID-19, we were, and these are just our Marion County Public Health Department patients and clientele, we were hovering around about 65 to 70%. That was before COVID hit us. Since COVID, we have dropped our vaccination rates down to 49% or rounded off to 50%. So half has dropped substantially. When we had to stay in shelter, people didn't have access to their primary care providers or the clinics, and so it's dropped down drastically. So we're really trying to beef that up right now. We're really trying to campaign, please get your children caught up with your vaccinations, and especially for the adults. We're going to also have a bacterial, the number one cause of pneumonia, bacterial pneumonia is pneumococcal vaccination. So it's like the triple whammy we're going to see this winter. So we're going to see the flu, we're going to see COVID-19, but we're also going to see pneumococcal bacterial pneumonia. So those immunizations related to that, please, if you're 65 and older, consider the pneumococcal vaccine. And then for those who may have some chronic medical conditions that put them at high risk, they should consider that as well.
Got it. But out of curiosity, I mean, we've talked a little bit about, the flu vaccine, which you have to get every year. We talked about polio, which required 2 doses in order to get that higher level of efficacy. And then I think on HPV, it was either 2 doses or 3 doses, depending on age, right? What are the differences between the vaccines where some are required, 1 or 2 doses, period, while some require kind of ongoing? And how does that connect to like the coronaviruses, kind of coming through now?
So I think with the coronaviruses, they're like 4 to 6 vaccines that are right out there. They're in their phase 3 clinical trials, and some of them, I think Moderna or some of the others are going to be probably giving their results out maybe in December or whatever. And it's the immunogenicity. I mean, Darren can probably talk a little bit more related to that, Dr. Brown. So depending on how much of an antibody that they can generate, and then having that additional boost immunity that sometimes can make your immunity last longer. For example, with herpes zoster now, we used to have 2 vaccines out, but now we have 1, which is 2 doses separated by at least a month. And so it gives you that double boost in terms of your immunogenicity. So some are just as strong with just 1 vaccine, and others with 2. It really increases not only the immunity, but how long that immunity lasts. And there's an influenza vaccine development out there that's supposed to last longer than 1 year, maybe even 5 years. So, some exciting work and developments are taking place right now.
I did not know that, so that's exciting.
Yes.
Dr. Brown, Dr. Zemet, anything to add on that?
Virginia's right. I mean, the classic prime boost way of giving vaccines, we've done it for many, many years. You prime the immune system by that first dose. And a month or 2 later, you show the immune system a second dose. The amount of antibody and actually the quality of antibody goes up, very significantly after that boost dose. Regarding coronavirus vaccines, I mean, I'm not a coronavirus expert. I do know, a fair amount about the virus and the vaccines being developed. these are all recombinant vaccines that are being developed. And depending on how the immune system sees that product that's in the vaccine will depend on the antibody levels. It'll depend on the likelihood that those antibodies will actually neutralize live coronavirus. So, we're all keeping our fingers crossed. As Virginia said, there are at least 4 or 5 that look good, but there's probably 150 different ones out there that are in various stages of development. And I have my own guess which one is going to work. I'm not going to tell you because I don't want to.
Oh, that's just terrible. You can't tell us. Okay, you can. Well, I don't know how to whisper it in my ear, but
the data,
after it's approved, you can let us know what you think.
Yeah, well, the data from the AstraZeneca trial looked pretty good. I mean, that's the one developed at Oxford University. We've got a high degree of immunogenicity that actually looks pretty good in, quote, older people such as myself. But I think that one's looking pretty good, and we're just going to have to wait and see if the efficacy is adequate to protect.
So this highlights a thing for me, if you don't mind me asking. So, I'm the section chair for infectious diseases for the National Medical Association. That's the oldest and largest Black physician group organization. And I'm on our NMA COVID task force. And so I will ask you the concerns from our Black African-American perspective, clinical trials that may take place, but they don't have a sufficient number of patients of people of color as part of their clinical trials. So my concern is the efficacy the same, because we may have different chronic medical illnesses that may trigger some kind of immune complex mediated response. We know about a sub-segment population now of COVID-19 patients that are having lingering symptoms, okay, and that are not going away. And so just I know how important it is to me, but tell me from a researcher standpoint, if you're doing a smaller trial and you may be getting that emergency authorization, how does that impact people of color?
It can make a big difference. And, we were cognizant of those issues when we did the HPV vaccine trials. In fact, in the United States, more than 60% of the participants were Black. And, but on the other hand, there were trials done in Europe and there were trials done elsewhere. No trial was done in sub-Saharan Africa, which always bothered me. But getting back to coronavirus, I mean, it is critical that we have a diverse demographic distribution, age, race, these are critical factors.
Even obesity. So that is huge based on the weight of somebody. Right. How effective from a distribution standpoint does that take place? And then since our greatest disparity in hospitalizations and death were in our seniors, what percentage of these trials are in seniors over the age of 65 and maybe having chronic medical conditions?
One of the problems with testing a new vaccine is you want to get relatively healthy young people in that trial. And that's the problem. The companies are rushing to get people enrolled and to have a very good safety profile. So as a result, I think we're probably missing a lot of people with comorbidities, older age, different racial backgrounds, et cetera. And that's going to, potentially come back to haunt some of the manufacturers. Greg, you want
to? Well, it can impact vaccine hesitancy. Sorry, just vaccine hesitancy for particular populations of color if they can't consider the effectiveness of the vaccine. I'm sorry, Greg, keep talking.
No, I'm going to speak to that in part. So I know that some, if not most of the companies in phase 3 trials have been working really, really hard to ensure racial and ethnic diversity, but have found it difficult in part because of the absolutely warranted distrust of minority communities, particularly African American communities, about clinical research. But they're aware. All I can say is they're acutely aware of this issue, and I know that they're all trying as much as possible to stratify recruitment, to recruit as many persons from minority communities as possible. They also, some of them are stratifying by age, so they are trying to get some older individuals. One of the trials, Pfizer's, they just got approval by the FDA to recruit down to age 12. So this, there's a lot going on with this, but as Darren was saying, Dr. Brown was saying, everything is moving so fast, which is good, but carries with it a lot of risk, a lot of downside risk potentially. But
so Dr. Caine, oops, sorry.
I was just going to say, I think the companies that are developing these vaccines are acutely aware of all of these issues.
Would anyone take a Russian vaccine?
No,
Sputnik 5? No.
Sorry, guys, I just had to put that in there.
Yeah, there you go. So this is a topic near and dear to my heart, and I think that perhaps an additional Frameworx at a later date and the importance of this. I mean, women were not required in clinical trials in the United States until 1996. So that was 5 years after I joined Lilly. I was 36 years old and pregnant with my first child. So for lots of reasons, as a friend of mine would say, and I think you probably remember Frida Lewis Hall.
I just talked to her maybe about a month ago.
Okay. She would say, even, no offense, but even the rats are white males. So I think that it's important that we get the word out and do everything we can to ensure that that sensitivities are understood and overcome, because this is not going away, and it's even more complicated because of the history, and now with the speed. So I just think it's a topic for another time, and you, Dr. Caine, would be someone who could give a very legitimate and authentic voice to this.
Thank you very much.
What a great dialogue. And I know we only have about 10 minutes left, and we got a few questions here, so I'm going to try to help us run through them. A couple of these are quick hitters, probably for Dr. Caine here, but how many pneumonia shots should a senior get and how often? And then also, should we get multiple shingle shots? So pneumonia and shingles vaccine question.
So let me just answer the shingles one first. So there used to be two products, one from GlaxoSmithKline and the other one from Merck. I think because the efficacy of Merck's vaccine was like around about 70% compared to about 98, 99% for the GlaxoSmithKline. I think most providers now are not using that Merck product, which is the advantage of it was just one shot. But I don't know. I won't name the name of the vaccine from a trade or brand standpoint, so I didn't put that on my conflict of interest thing. But I will say that it is 2 injections, and it's just important, like Dr. Brown says. The first injection sort of primes your immune system; it's ready to go, and then with the second injection, which is at least a month later, really boost up your antibodies. And on top of that, the immunity lasted longer with this vaccine compared to the prior vaccine with the 2 shots. So critical to get this, because we are seeing an increase in herpes zoster during this COVID-19 outbreak, and so that's really important. Now for the pneumococcal vaccine, we primarily recommend it after the age of 65, and it usually lasts 5 years from an immunity standpoint. But, there's certain, you can be children and you can be immunocompromised and whatever, and so you may require that vaccine as well, and you may have to get it multiple times after the immunity lasts usually for about 5 years. So they may require some multiple vaccinations later. I don't know, Darren, you're also the big immunizations guy. You probably have the better answer than I am.
That was a great answer. I can't really, say it any better. I mean, I see patients in clinic, and we recommend vaccines, and you hit it right on the nose. I mean, I just want to say once again that as a physician, I believe that vaccines are the safest and most effective things that we do. And, pneumonia vaccine, adult vaccines are just as important as childhood vaccines. And, if there's another version of this conference down the road, it might be good to talk about some of the other vaccines that are really important for both children, teenagers, and adults.
Yeah, meningococcal, for a lot of college students now that are popping up, that's so critical and important for us to really be pushing out. And so, we recently had our measles outbreak about 2 or 3 years ago on our college campuses. So we really have to be very cognizant of the immunizations for everybody. And just got to encourage everybody. A lot of people have missed their regular doctor's visits for like 8 or 9 months. So quickly, we need them to get in and get themselves checked out by their providers.
Makes sense. All right. Oh, Patty, go ahead.
Sorry, I was just going to say, Dr. Caine, I became aware through my kid's pediatrician that there's a website, and I'm not going to know it off the top of my head, where they enter the vaccines into an Indiana State vaccine website. Should we make that available to folks so they could be aware, or how do we get our information in there?
So actually, those reports are entered by the healthcare providers. So when your child gets vaccinated, we have a statewide immunization vaccine software database. And so all providers are required to submit to that. And that's really critical. And it's really complicated a little bit because you have to put the vaccine's lot number and everything, because everybody, there's so multiple flu shots and so it's so important. We want to know if we ever have any safety or efficacy issue or whatever, we'll know the particular vaccine that they received.
Virginia, is that de-identified data? I mean, do people's names get attached to those? Yes,
so they send their names of the patients to that software database to the Indiana State Department of Health. So it's at the Indiana State Department of Health. And they have to send the names because, sometimes it could be duplication and somebody else may send it. So they want to make sure that the data is accurate.
I think parents can access their child's records through, it's called CHIRP.
Yes, it is CHIRP. Yes, exactly.
Yeah, so as a researcher, you can access CHIRP. Like I've used CHIRP data, but not individual identifiable. So what we did is the county level data, which is completely de-identified. But
you have to go in and log in and get a code and all kinds of HIPAA things. But yeah. I encourage folks I was not aware it was out there, and I think that parents should know. I don't know how many times I've had to get immunization records, signed off for my kids, and it's just, you forget. I mean, my kids are in college now, and I think I need to revisit and figure out, what's next. It's tough when you're not in the habit of having regular visits like Darshan is with his almost 1-year-old.
But here's the thing, just think about it. How many multiple new infections we have had just in the last 10 years. West Nile, Zika virus, Ebola. I mean, I could go chikungunya.
Well, we're still.
That's what I like my little nickname for it. Okay, dengue. I mean, there's so many new viruses that are popping up now. Started with H1N1. So scary.
When Virginia and I were fellows, and I won't say when.
Thank you, Darren. I appreciate you. I always knew you were a smart guy.
Yeah, that was the HIV pandemic. It began then.
That's exactly.
you know, we're still waiting for an HIV vaccine. That was 40 years ago. You know, think about it that way. We still are dealing with a virus that kills nearly 1 million people per year worldwide. And, you know, we need a vaccine. And, you know, Virginia is right. There's always something new in the infectious diseases world.
I wanted to mention that, so there were 2 questions from one person. I typed in a quick answer to one, but I also wanted to make sure that other people get a chance to. So she had asked, do vaccines in some cases, if they don't prevent infection, reduce the severity? My answer to her was yes in some cases, because I know that's true for influenza vaccine for certain.
Exactly.
But I don't know if it's true for other vaccines, but I wanted to make sure she got that question. She has another question as well.
And we're probably going to need to answer that question offline. So anyone else has questions, feel free to submit them, because we'll get an opportunity to email them out to the panelists, and we'll still be able to respond back either via email or via a future newsletter. So so if you have like last second questions, you're like, oh shoot, I'm not going to submit it because I think we're out of time, send them in anyway. And so I'm going to ask one final kind of closing thought kind of question for you all, and ask you to kind of keep it to about 30 seconds or piece if possible. But we're obviously talking vaccines today because we're in a race to develop a pretty important one, you know, obviously for COVID. In your closing remarks, if you don't mind sharing your insights on what we can expect in the coming months or even years as it relates to the development acceptance of a vaccine for COVID-19. So let's go around the horn and start with you, Dr. Zimet.
So what can we expect? It's going to be a challenge like HPV vaccine, but it'll have different features. I think because, you know, we've seen in repeated polling, interest in intent to get a COVID vaccine has been dropping precipitously. And I think there've been real problems with the way things have been communicated. So my concern is that we'll have a vaccine that's definitely, you know, somewhat efficacious, maybe 50, 70%, but if only 30 or 40% of the population gets it. So, you know, I think the kind of research I do is still going to be relevant, because I think we're going to have communication problems. And if we want to achieve herd immunity the only way it's ever been achieved, which is through vaccination, then we're really going to have to work hard at that, because I anticipate there are going to be a lot of problems.
Dr. Brown?
I think we have to really focus on the safety issues of vaccines. And once we get over the safety hurdle, it's a lot easier to do the things that Dr. Zimet and others really want to do, which is to encourage people to actually receive the vaccine.
Patty?
I'm just going to say we're here to spread the word. So thank you. I'm going to thank all of our panelists. And before I hand it over to Dr. Caine for her answer, we'll get the word out on additional Frameworx. Darshan, you did a great job facilitating the panel. Dr. Caine?
Well, I'm going to just carry it from a little perspective. So one, by the year 2030, 50% of this country will be at a different of people of color, between Hispanics, Latinos, and other racial and ethnic groups. So 50%. So in terms of being effective with our vaccines, we have got to address the vaccine hesitancy related to that group. But I think pharmaceutical companies need to realize the efficacy in those populations, because for the future, that's going to be really critical to their business and their operations in terms of the safety and the effectiveness of what we're putting out. Now, one, the COVID vaccine, I don't think will be in sufficient quantity until next year, probably in the second or third quarter, in significant amounts for the general public. We may have something early, like January, for our essential healthcare workers, and maybe for our seniors, but not until probably April or May will we start to see large productions, I believe, of vaccines. But we have now got to the point that we've allowed this virus it gets so embedded in our community. I think it's going to be here for, like H1N1, it's still going to remain in our communities despite the vaccinations. And so how good we are with our communications and addressing vaccine hesitancy is going to make the difference in terms of curtailing this COVID-19 response.
What a great call to action to kind of end on. And thank you all for just an incredibly wonderful kind of informative discussion. And as we mentioned, and Patty mentioned at the top of the conversation, this is the first of a series of events that we're going to do around vaccines. So please stay tuned as we talk about, obviously COVID-19 and others in the future. And we'd love your feedback on what we should discuss in the future in regards to vaccines. And clearly, based on what we've heard today, there is a lot of interest and a lot of kind of importance, kind of focus around, focusing on minority population and clinical trials and figuring out how to kind of improve adherence kind of within those populations as well. So that's clearly something that we've kind of taken kind of resoundingly. But if there are other ideas from the audience, we would welcome your feedback on what we should talk about going forward. So leave the comments in the Q&A, message us through our website, lots of ways to get a hold of us. Follow our Twitter, sign up for our newsletter so you know about our future virtual events. And lastly, just thanks for spending this lunch hour with us. And this is such an important topic, and looking forward to you spreading the word.
Thank you
so much, everyone.
See you, Greg. See you, Darren, Patty.
Bye, Jenny. Bye, Darren.
Bye, Greg.
Mr. Shaw, nice to see you, meet you.